Hey, my medical coding family. It's good to see you guys. Sorry about the delay. You know me, I'm always trying to fix something on my computer. I almost have this perfect. I'm still trying to figure out why chat is not showing up on here right now. Um, is my only issue. I'm trying, but hey, Lester, let me hit refresh. Does that work? I'm like, why are you not working? That's the only thing is I can't see chat on the replay. I can see it somewhere else, but I was hoping you guys could see chat. Anyway, I almost have all this set back up the way I had it before, where I have my little emote girl and I've got our camera. Oops, looks like the camera is not working, right? Because I can't see my fingers. But I do have the practice questions going. Hey guys, can you guys hear me and see the screen good? You like the little Jen girl? Me too. I do too. I made her all by myself. If you get a chance. Sorry, I was just telling the IT director that if he's got time to come by and swing by, but I paid an artist on Fiverr to create her, and then the artist on Fiverr just gave me the images, right? So then I went to this YouTube thingy and learned how to put her into our live stream. It looks like the camera is not working and then chat is not working, but I have chat and I keep hitting refresh and I put the good link in. There are minor things that I don't really need them for today, but I'm just like, oh yay, there's our camera. Do I have to keep, is there a reason why? Okay, and then chat, I do have right there, and the link is in there properly, but it's not, that's the link for today, but it's not showing up today. Oh, the color, black. And I do have it. It is on. It is on the thing. Yeah. There it is. Yep. You just had it. We're just seeing if we can't fix some of these issues. Yeah, I'm sorry. My audio is kicking in and out. I'm walking away from the mic. Sorry, guys. You guys have a question on the screen. We're on Pocket Prep. You guys can work on this one. What do you think is your correct answer? What's your strategy? Are you going to look at your ICD-10 codes or your CPT codes? Which one would be your strategy for this one? Which one would be fastest? Hey, Corio. Hey, Go-Kart. Thank you much. Thank you all for the thumbs ups. Like Go-Kart says, let me pin her message up there. That tells YouTube that you are liking the live. That helps out a whole bunch. Appreciate it. Hey, Eamon. Hey, Sush. Good to see you. Did y'all join in on our workshop yesterday? I recognize a lot of your names. Indexing, you're trying to work on your indexes. So you'll go straight there. What did you do today? Evaluation and management codes are in your index. You can index those if you wanted to. It's just being stubborn. If we've got let's go over here. See, evaluation and management services can be indexed, and you can utilize this area to pick out your correct answer. If we're 99466, then you know you're in PICU. If you're in 99471, you're in infants ICU, or children's, I guess you should say, 2-year-olds up. So age matters with all these codes. What do you guys think is the answer? Someone said B. Is that where a 15-monther goes? And do we have 1 or 2 diagnosis codes? We have pneumonia with acute respiratory distress syndrome. B is correct. Good job. Perfect. Anesthesia is next. What do you guys think about this? Got 19 of you still on. Just checking the YouTube to make sure I'm still streaming. Y'all are awful quiet in chat. What do you guys think? Where in anesthesia would we be? Let's says she likes C. Heather also. Perfect. Excellent. Good job. Now we need to know if we can add that 99-100 code to these codes. You can't tell unless you go to the codes. Unless they're an older adult, over 70, usually those get added that qualifying circumstance code. But with the peds, you gotta verify and make sure that age is not already inside the code descriptors before you do those. Like example 00326, it already includes a patient's age that is younger than 1 year of age. Then you would not use a qualifying circumstance code to go along with it because of that. So verify with these first to see if you can add that qualifying circumstance code, since this child is 11 months old. know in chat what you think the answer is. Ooh. You had to do that once before. I remember that. That's a pain. You like A? Repair of a cleft palate? Perfect. Excellent. Good job, Heather. Your exam is coming up on Thursday, right? Oh no. Don't second guess yourself, go-kart. That's how you get them wrong. Remember to look at your headers first for your available answers, and then your last sentence. Verify that you know what they're wanting you to code for before you look at anything in your exam question. Answer A is subsequent hospital visits. So is B. What's C? That's something different. That's an office consultation. Not only is it not inpatient, but it is a outpatient service. And then D is an inpatient service, but it is not a subsequent visit, so it is an admit-only code. Our last sentence says to code for Dr. Woodman. So then you would just look in your exam question and see what did Dr. Woodman do. All the rest of the information about Dr. Peterson and Mrs. Holland, ignore all that. Only look for what Dr. Woodman did today and bill for those services. I had it right the first time. Yep. It's Wednesday, Heather. I don't know why I thought Thursday, but it's coming up. Remind me again, are you going to a testing center or are you testing at home? If you're going to a testing center, be sure and put gasoline in your car, charge it up, all that stuff on Tuesday. Put your manuals in the car on Tuesday. Okay, good. Did you do the pre-test where you scheduled with measuring? Like tomorrow you could do this, your mock exam, so that you can log on. The proctor will come on, check your room, check your camera. You have a jar of peppermints. That's awesome. You may have to unwrap them and take them out of the jar. If your jar has any or words on it, they won't allow it. So be sure and you're yay! Y'all see chat now? Shape it. Yep, I can adjust it. Thank you so much. I know that was stressful. Yay! I'll see chat now. That's great. Let me put this where it needs to go. That was my IT director working here the whole time to get that going. Sorry, that's a little small, but I'll work on this and we'll get this fine-tuned. I want y'all to be able to see if chat goes through or something. I know that's a little small. Let me make it bigger. Some of it you might not be able to see. Maybe let me just get but I can read it. But just so that you guys can see enough of it so that you know whether what you typed went through. Y'all are saying B for this one. That one was D. This Dr. Woodman, all he did was admit. So if we look up here, we're billing for Woodman's services. Let's see. Decides to consult with a rheumatologist. Let's see what the explanation says for this one. Yeah. So I think we have the wrong answer picked because from their rationale, it says that these codes are for subsequent visits. This was Dr. Woodsman's initial visit with the patient, even though it took place on day 4 of the patient's stay. Interesting. I know that if a consultation is done prior to admit, that those are coded as subsequent hospital visit, but this one is, I don't know why they would call this an admit only. When the patient had been admitted for 4 days. Ms. Holland will continue the injections and after she's discharged. Let's see. Which part is tripping you up? Let's see. I love how, let me show you guys a little bit about what I'm doing here. So I'm asking them how they come up with this answer, right? So they have this new feature inside here about like AI generated, right? It's a tutor situation. So I'm saying, okay, this is tripping me up. Why is this an admit? Okay, the patient was already admitted and this is day 4. Why is answer 99222? Let's see what it says. Dr. Peterson is the admitting physician, may have already seen the patient on the day 1 through day 3, but who sees her for the very first time on day 4? Dr. Woodman. Right. That's the key distinction. Initial or subsequent hospital care codes aren't different subspecialty. Is that what it is? Is it a subspecialty? no matter what the day of admission was be. What? Not quite. Not all subspecialties, okay? Even if the Dr. Woodman was a different subspecialty, okay? The first visit with him is always initial. GLOB and Global Admit Guidelines, though, prevent double admissions on same patient. Dr. Woodman isn't an admitting provider, he is a consulting. So there's a question to work through. Does the one initial visit per admission rule apply to every physician who sees the patient during the stay, or specifically to the physician who holds the admission? So here's the question to work through. Yes. You can only have one initial admit per admission. I know Dr. Woodman isn't the admitting physician, but the patient's already been admitted. Did Dr. Peterson discharge the patient from their care? That's what they're saying for this one, go-kart, is that it's initial, and I'm still not seeing it. Unless you can only have one admitting physician and only one consultation per admit. How can we have another admission or admit doctor when this doctor was consulted? If they're going to give them the first time, why isn't it been a consult? Physicians can just willy-nilly bill whether their patient is new or established whenever the patient is in the hospital. And so they can just bill. That just sounds crazy, but we'll move on. Yeah, that tutor cannot be correct. Yeah, I'll ask Pocket Prep about that question tomorrow. It could be interpreted that way if that hospital has policies and procedures written that way. I mean, it is the United States and everything is the wild, wild west. We have nothing that's universal, but I've never seen anything like that. The only way I could see it being a new admit is if the Peterson had finished with the patient, right? And then this doctor was, admitting them for a separate condition under their specialty, right? Because Peterson may have been cardiovascular and the patient's cleared cardiovascular, they're good to go home, but then their rheumatoid flared up, right? And that made a new condition that made them to where they couldn't go home. Maybe I could see another initial admit there, but Peterson would have to be completely done with the patient, right? That would be crazy. All right, this 71-year-old patient, we know that they need what code to be going along with their anesthesia? Yes, we need that qualifying circumstance code. Perfect. That narrows you down to just two codes, two available answers. Then you only need your 14 and 16, which is super cool. Everybody saying C? Oh, it was A. It was the 14. I didn't even look at it. Let's go look. Let's see what our differences were. 7, 14. Were we doing an elbow to shoulder or open procedure? What was this under anesthesia to repair upper arm? How do you know if it's opened or closed? Placed under anesthesia to repair the upper arm. This is not telling us. This one is plasty, which is a repair. Otomy is a removal or an incision into. Repair is 14. And 16 is a ruptured tendon in the bicep. Yeah. So 14 plasty. Remember that in the beginning of the book where it showed you the instructions for how to use this book? At this area, it's got a list of prefixes, suffixes, that kind of stuff. Repair, if you look for the word repair, is under the word plasty. P-O plasty, P-L-A-S-T-Y. So when you're looking here and you want to know which one goes to what, plasty is the one for repair. Yep. All right, what about this one? We have admit and discharge all in one code. We have discharge. We have that subsequent hospital visit and another discharge. We have two discharges. What are we billing for today? business of medicine notes, the end of anesthesia. Let's look at our discharge codes. 38 is for 30 minutes or less, and 39 is for more than 30 minutes. What do you guys think is the answer for this one? No, I don't want to do that. I don't want to do that. I'm sorry. Don't forget, you guys can take your string for today, of course, turn it long ways. You can tap on the screen and click on that little wheel at the top, and you can change the quality of your playback to a higher quality. Do it twice, because that'll give you the option of changing it to a higher quality, which you can see that it defaults to 720. You can change it to by hitting the advanced button to 1080p, which changes your quality to a much bigger one. So pretty cool, just in case you ever wanted to make the screen appear better quality instead of cheaper quality. Anyway, hope that's helpful. Chat is pretty big. It looks too small on my end. I'm watching on my end. It seems to be going pretty good on my end. I don't see any issues. No spinny wheel of death or anything. Might be just your internet Wi-Fi connection. Be sure you've closed all your apps on your device so that this one is the only one playing. What do you guys think? Oh, I could turn off my bathroom fan too to make the audio a little bit better. What do you guys think is your answer? You like D? D is perfect. I'll give you this new question. Let me go change that bathroom setting. Let's see if we still have a filter on the mic again. No filters on the audio, but I turned off the background noise. Maybe that'll make a difference. All right, what do you guys think about this one? Do we have a new patient or do we have an established patient? Perfect. Then what level visit do we have? Level 2, 3, or 4? We do have 31 minutes documented. Where would 31 minutes fall? Another D. Perfect. Good job. More anesthesia. You can go to your index in the back. Oops, we do have a big area back here for anesthesia. Make it one more book. Prop this up on. Anesthesia is in your index, and you could go to sinuses, maxillary, make it even taller. There we go. Y'all like D for this one too? This one was B. We go to anesthesia for debridement of the maxillary, frontal. I wonder if it's under max. Post-dural puncture. Ooh. Good job. If we're going to be doing a blood patch for a CFS leak, what would we look up? I'd love to do Practicode anytime you guys want to do it. Are you working through those right now? D is in dog for this one. Are we dealing with a new patient or a consultation with this one? Patient was referred by their PCP to their endocrinologist for hypothyroidism consult, and the endocrinologist specialist will send a copy of the report back to the PCP. Does that qualify as a consult? If it does, was the patient's status admit in the hospital? If they were not admit, then you know it's got to be C or D based off time or MDM. This says about 30 minutes. Remember that you have to meet or exceed in E&M in order to bill it. You can't just about make it there. You have to make it there or go over it to bill it. So be careful about that wording. Indeed, C is correct. Good job. And what about this one? We've got an 85-year-old. Is this patient a new patient, or are they established? That will help get you down to a 50-50 shot. How old are they? 85? They spent 45 minutes with another 20 minutes with the patient, so that was a long old time. They gave the patient a 344, which was C, way down here at the moderate, for 60 minutes or more. If you add the 45 minutes and the 20 minutes together, you do get 65 minutes. So that's how they came up with that one. What about this anesthesia? anesthesia. Is our patient a P1 or a P2? Would we use the modifier G9 or QS? Do we have any information on the patient's physical status prior to getting this fracture at all? No, no info. Yeah, Adam Walker could be 9 years old. They could be 50 years old. I don't know. I don't know anything about Adam, do I? No systemic disease. Nothing telling us that they have a history of hypertension or anything like that. They could be a pediatric patient who has polycystic kidney disease or something. You never know, but we don't have any information. We know we did use monitored anesthesia. What modifier gets added to anesthesia for that? And then if we don't know that they are a P2, then what would our answer be? They're going to say P2. Let's look at our anesthesia numbers. 018. 018. 60 versus 30. 60 codes are for arms, wrists, hands. And 30 codes are for radius, ulna, wrist, hand, joints. And then our 30. And then our 60. But that's just for cast application, removal, or repair. Yep. Definitely would have had to have had the 30, but and the QS, but how you know your patient is P2, no idea. What they say here. In Appendix B, HIPICS code, QS modifier, a note that it is for monitored anesthesia care that is rendered in this procedure. In the same appendix, locate P2, you'll note that it says that the patient, which the case refers to as diabetes. There's no diabetes listed in this case. Not that I see. Does it say DM somewhere? They lost their minds. I don't see any diabetes listed. You read open, so you didn't choose it. Does anybody here not have pocket prep? Does anybody here not have a subscription to Pocket Prep? Sush. Samantha Williams. Okay, Sush, Samantha, and Tanya. Okay. Okay, you three. Sorry, I got Sush, Samantha, and the Tanya. So the first three that replied, email me with an email address that you guys want to use as your subscription. Coding by jen@gmail.com. Email me there with a valid email address that you want me to use, and I'll send it to my Pocket Prep team. They gave me 3 that I can give out subscriptions, and I have Sush down, Samantha, and Tionya. You 3, since y'all typed faster. And then they'll probably give us away 3 more for next month too. So I'll add you in next time, Wilson and Kay. All right, I wasn't paying attention to this question. I got more B's for this one, so I'm gonna pick that one. There you go. This question, you're welcome. You're welcome. You're welcome. It's 1,000 exam questions, and some of them might be a little wonky. That's okay, but it's still great practice. Plus, you can have the app on your phone, and you can practice exam questions while you're standing at the line in the grocery store. You can work on the process of elimination, looking for similarities, just clicking on answers without having to worry about, you know, how many exam attempts do I have or something like that. It's pretty cool. I've enjoyed Pocket Prep for a long time. Since 2019, I've had a year-long subscription to them, and I love using their practice questions for sure. And if I have any issues with their questions, I do email them. They have a help button on the side. They will get with the question writer and send the question writer your concerns about their question, and then they'll email you back their rationale and why they think the answer is what it is. And if they agree with you that, oh, that is an error, they'll fix the question. So that is really cool. It's really, really cool. I can't even get aapc to fix their errors on their practice questions, and they do have them too. Everybody has errors on their practice questions just because we're humans, you know? We're all typing, and we're only as good as we are humans. I mean, it's just part of it. The normal error rate, as long as it's less than 7%, is acceptable in any literature that's ever printed. So even your calculus textbooks or medical journals are allowed to have 7% error rate in them. So it's just part of it. I'm sure it'll get better one of these days as AI gets better, but for now it's still going to be just as bad because I don't think AI can figure out medical coding as it is anyway. But just want want you to know that there are errors everywhere. Even in Bucks, the 2026 Bucks book, I already have found errors inside it. So it's just part of it. We're all human. What do you guys think is the answer for this one? Would we have 1 or 2 codes? And which one would it be for a 90-minute evaluation? Everybody saying C? It was D, guys. Some of them are for just physicians, and some of the codes are for non-physicians, so be careful on those. Yeah, that question, Go-Kart, the one with the P1 and P2, refers to the patient having diabetes type 2. Well, our version of the question that we're seeing does not refer to the patient having diabetes, so there's an error there, so I'll let them know tomorrow. They'll fix it. Heather says B. It was D times 2. When your doctors are doing standby services, right? Standby, you're always going to be coding your 60. And then for each 30 minutes, they get the code 60. So this would have been times 2 for that standby services. Anytime you see that in your question, know it will always be your 60 code. What do you guys think about this one? Moderate MDM. Now they're saying D. D is perfect. Good job. All right. Is our patient new or established? That'll make a difference here. And then, are we a nurse visit or low-level visit? Good job, Anna. Perfect. All right, anesthesia. got our OB ones, right? Somewhere around in there. Yep. We've got 1A, anesthesia for a C-section. All right. Perfect. Good job. Back to the skilled nursing codes. What did we do today? I messed up the thumbprint of my thumb. I don't know if you guys can tell, but like my thumbprint is gone. And it's so annoying because I can't open up my phone without punching in the code. I hate that. It's so annoying. It's like it's me. Open up. Are we doing a discharge or are we over here under initial visit? What are we doing today? Everybody saying A? Perfect. Good job. Excellent. Anesthesia for a punctured lung. Where would we be? 005? And the fours? I see you. Y'all are funny. Y'all like A for this one also? Uh-oh, we were a 47. Let's look. 47. 474. Radical procedure under partial rib resection. We're there to remove some muscle tissue. Pectoris. What is the muscle called in your chest wall? Excavitium. Yep. I love working through all these questions with you guys. Which of the following criteria is required for an evaluation management code selection? Should we be following the patient's recovery? Does time need to be documented? Do we need to have marital status? Probably at some point, but not yet. Or do we need history? What do you guys think? Perfect. Yep. Easy peasy. What about this one? Make it bigger if the font's too small. There we go. This one, or anesthesia in some sort of obstetric setting, will probably likely be on your exam. Somebody's having it done on Wednesday. So yeah, super. Be sure you familiar yourself with these codes for sure. Which ones you can use with each other. Most of the times you cannot use anesthesia codes together, but there's one obstetric situation that happens that you can use two of these codes together. Everybody saying B? Perfect. Good job. Ooh, this is a big old case. I probably have to make it too small for all of it to be on one page. The only thing you're missing is that it's a 3-month-old male with Kefla syndrome, with shunting, pulmonary hypertension, that kind of stuff. What would we be billing as far as an E&M visit goes? You do need to know their age, and they are 3 months of age. They're 3 months old. Where would they be? I can make it smaller, but y'all ain't gonna like it if I do. Ugh. There we go. So tiny. So tiny on the screen. Oh my gosh. I'm like, ugh. You like B? Perfect. Good job. Excellent. All right, let's make this one big. There we go. What do you think? Are we doing a consultation? Are we in the ER? Are we doing a hospital consultation? What is our status? What's going on? Y'all like C? Perfect. Good job. More anesthesia. Are we a P3 or a P2? Wilson likes D. Perfect. Good job. More anesthesia. Aneurysms. What are we doing for this aneurysm? We're going to be over on that side. C. Good job. Perfect. Excellent. Breast reconstruction. We're doing a trans flap. Isn't that inside one of our code descriptors, maybe? Maybe the procedure code. I don't know if it's in the, might be in the anesthesia code. Sometimes they put those name brand names, certain procedures inside the little bracket things in your code descriptors. A is perfect. Good job. Excellent. Are we dealing with a consultation, a subsequent hospital visit, or a discharge? Don't forget to look at the available answers in E&M. What header are they under? And then read your last sentence. That way you know what you're billing for. Doing discharge for 45 minutes. 238-99238. I hate all these telemedicine codes all up in my E&M way nowadays. Absolutely hate those codes being there. Where would 45 minutes be? Correct. C is correct. Good job. Good job. Remember, anything more than 30 minutes would have been 39. Don't second guess yourself. Are we doing woo-woo? Anytime I see the 8-8, I think of the two circles as being ambulance wheels. So 8-8 is ambulance. Consultation, ER, or critical care services. What are we billing for today? This kind of question was on my instructor exam. Good job. Are we a P1 or a P2 again? An ambulance or an anesthesia, I mean. We have the AA modifier all the way down on every answer. So we know an anesthesiologist is doing this themselves. Does say overall healthy patient, doesn't it? Now, are you a 402 or a 380? Super tricky differences between those codes. Did you do a total knee replacement? Or are you scoping the joint? P2 is for patients who have a mild disease. Why would we put a healthy patient under P2 when P1 says healthy person? So answer A has somebody with a disease. Okay. Answer C is perfect. Good job. Is this patient established, new, initial, or subsequent? What category would this patient fall under? North, south, east, or west? Established is A. B is a new patient. A 17-year-old who's been coming to this medical group all her life. She's been seen by the internal medicine team during that time, and now she's made an appointment with her gynecological visit with this same medical group. What's the classification of the patient who's seeing a GYN? Is she established? New, initial, sort of like the same thing, huh? Which is the best answer? B is correct. I don't think very many picked that one. Remember, subspecialty matters. That's why I was asking that in that hospital one. That was a little wonky, that I'm like, unless there's a subspecialty issue, I mean, you can't say that was a new admit. I don't know. But anyway, if they've seen an internal medicine doctor and then they go to see a rheumatologist, even though they're in the same group, they're different subspecialties, and you can bill for new patients when you see different subspecialties in the same group. All right, what about this question? Where are we? Are we in like a nursing facility? Are we an established patient? What are we doing here? $20 minutes? Where would 20 minutes fall into play? Correct. C is correct. Good job. Good job. Perfect. All right. Are we a level 2, a level 3, level 4, or level 5 for this patient? I'm glad you love it, E&M. I refused to learn it for my CPC exam. Back then, the exam was 150 questions, and you could miss a whole lot more than you can now. So I refused to learn it. I knew the basics, like what's a new patient, what's a consultation, what's an admit, what's a discharge, but basically didn't know but maybe half of it. Didn't want to learn anything else. It was just too much to know. By the time you add on all of anesthesia, all the way through medicine, and then HIPICS and ICD-10, it was just too much. My brain was going to explode. It does. It does feel like a lot. The main thing is, 74% of the exam is CPT, everything from anesthesia all the way back to medicine. Learn that. Six questions each section, from integumentary all the way through medicine. That's where the meat of your exam is. If you know the basics of ICD-10 and HIPICS, that'll help pick up the rest. C. Oh, they picked low for this one. What are they doing? So she's got several chronics, which makes that, right, probably moderate, but what'd she come in today for? Follow-up. And then data, you can't count any data because it was ordered the last visit. So data would be 0 this visit. You can't count it the day you review it because you counted it the day you ordered it. That's called double billing. It's fraud. And then she was advised just to do over-the-counter medication. There was no drug management with this visit, so we can't do 2 moderates for her. So it's just a low. Yep. They didn't write any prescriptions for her chronic conditions, so that makes this a low. Be careful with those. Yep. You're welcome, Zen. Happy to be here. Happy to hang out. We're going to do another class this Friday. I hope to see you guys in it. We'll be in Zoom. Now that I got my system working, I know Zoom's working over here with 2 computers running at the same time. It should work much smoother than last Fridays. We're going to have fun. It's kind of like this, but they're questions that I vetted and put into Zoom, and then they go straight to your computer, and you have to answer them alone without chat, right? I'll give you 2 minutes per question, and then I'll get back the class average. It won't tell me who got them wrong, but it'll tell me like 50% picked this answer, 40% picked that one. And then we'll go over the questions, tell you what went right, what went wrong, how to even find the answers even faster than probably what you thought of. And those are fun classes. We'll do that again this Friday. Hope to see you guys there. It's my last week of the boys home for the summer. They start back to school next week. Senior year for both of them. D. Perfect. Good job. What about this one? We got anesthesia for repair of retina, eyes. Ophthalmology. We're thinking D with this one also. What are y'all doing? Let's see. 00145. 145. We got retina. Yeah, maybe. Because the other ones were cornea, lens surgery. Excellent. Perfect. All right. What about this one? Is our patient new or established? That's the first thing to work out. Just gave out 5 memberships to the YouTube channel. So 5 of you guys will have access to podcast, old workshops, the old Friday classes, all my book prep videos where you get to see me make my notes and stuff. There's even Practicode videos too, now that I have the license for it. So Honey, Carrie, Cool Kid, Danny, Heather, yay. And then we have Sush, Sam, and Tanya, who won the Pocket Prep subscription membership stuff. So I'll email those email addresses out, Pocket Prep, tonight. They're pretty fast about getting right back to you and getting your stuff to set up for you. Just make sure it's a good email address that you guys sent me so that they can get a hold of you to give you your logon and password. Pretty cool. 8 giveaways today. We know the patient's established, so we would not pick anything from A or B. That gives us just C or D. Are you a straightforward or are you low? What did they come in for today? $15. C is correct. Good job. Perfect, guys. More anesthesia. TURP procedure. 009, 10 in this area. We start back in 18 days. Gosh, not these kids. They start back. What is this? 1, 2, 3, 4, 5, 6, 7 more days. They start back to school. That's crazy. Travis starts back cheer practice tomorrow for this season. Yep, my 2 seniors. We got C's and B's. Let's see, B is 10. It's for NOS. 14 is for transurethral resections of the prostate. What does TURP stand for? Somebody knows what TRUP stands for. Anna, do you see it now? C is correct. Knowing your acronyms and what they stand for helps out a whole bunch. When did we get out of school? We got out of school May. Well, they don't go to school on Fridays all year long. So I think their last day was the 28th of May. Could have been the 21st. But one of those two dates, the 21st or the 28th of May. It went by fast. You think you would love to cut some radiology? Louisiana has a mental health day, but Texas does not. Yeah, I can imagine that. They went through Katrina, and Texas really hasn't had that much of a natural disaster of sorts, really. I don't know. We got some A's and some C's. Oops. $50 or $52? Simple ligation or major vessels? We're dealing with vessels. $52 is dealing with ligation, simple ligation. Perfect. Good job. Spinal manipulation. 0640. Or 70. $70 includes the spinal cord. 40 is for closed procedures. 20 is for the thoracic spine and cord. And 04 is for a patient who is sitting, but it's work on their cervical spine. D. Perfect. Good job. Are we dealing with a discharge, which is A and B? Are we doing an admit and discharge all on the same day, which is C? Or are we admit only, which is D? What are we billing for today? Patient was placed in observation for 3 to 4 hours, and then she was discharged home. What do you guys think? If you're going to bill a hospital discharge, what do you have to have in your exam question? You need to have time in your question so you know whether to bill above 30 minutes or below. If by chance you don't have time, your default would always be the 38. If you're going to bill answer C, you have to meet the guidelines which are on this chart on page 22, and the only time you can actually bill those codes is this one line right here. The other times you have to bill other things. The only time you can bill those 3 codes is if your patient was in observation greater than 8 hours. Our patient was in there for max 4 hours. That means if it's less than 8 hours, you have to bill what's right here. And then if your patient is Medicare, all that goes out the door anyway, because Medicare doesn't pay for observation anyway. It does in one particular area, and that's only if post-op surgery. If you have a patient who went into surgery and they're not coming out of anesthesia appropriately, and they need to be placed in observation because they're not waking up from anesthesia, then they'll pay for observation, but only as a post-operative thingy. Anyway, before you bill this 99234, 35, and 36, know that you can only do it in one very specific tight window, which deals and has everything to do with time. Anything less than 8 hours, you bill admit only. Yes, and when patients are admitted, which this right here is an admit, when you have a patient admitted and discharged all in the same day and it's less than 8 hours, the only thing that doctor bills is admit only. Indeed, D. Perfect. Is our patient new or established? If they're established, are they seeing a nurse, or are they straightforward or low for today's visit? Everybody going with C? Perfect. That is a nurse visit. Good job. What about this 8-year-old? Is the 8-year-old new or established? Are they low or moderate? D. Perfect. Good job. Yay. Excellent. Anesthesia. Whipple procedure. Where would we code a Whipple procedure? Y'all going with B with this one? Perfect. Excellent. The 3 elements of MDM. What are our 3 elements? I like the 3 elements way better than I did the previous guidelines we had. That was adding up body organs that were reviewed during the physical exam. That was a nightmare. Ugh. This is much easier, although I think the 3rd element is still subjective. I wish they would have a better, clear understanding of the 3rd element, but it is way better than it was. Anna, look again. They're asking you about the 3 elements of MDM, not the elements of a patient's medical record. Go-kart, fast forward your video. I think you've rewound some. I think you're behind us a little bit. Indeed, D. What about this one? Are we new or established with this one? Another nurse visit. Good job. What about this one? Are we doing a risk assessment wellness, or is this an established patient follow-up visit? What have we got going on? Are we high level, moderate level? What are we here? If we're doing an annual, then it's based off their age. And if they are new or established, where would a 48-year fall in line at? D is perfect. Good job. All right. Are we doing a consultation, inpatient or outpatient, or is this an established patient? Moderate level? What are we doing today? $11:30 in the morning, same as last time. If we're doing a 40-minute visit and we're moderate level, what answer would be correct? Performed in the office. So we know B is hospital. We know that C is in the office, so is A, and so is D. Everybody likes A? Perfect. Good job. Medical team. What about this team conference? You know that B and C are not team conferences. Those are regular office visits with a physician. So out of A and D, which one would cover direct patient contact? Half are saying A, half are saying D. 66, team with patient non-MD is what my notes have in it. And then my 68 has team no patient non-MD. So this is with direct patient contact. So the one that has with patient is which one? Because this one is without patient contact. No patient contact. Draw a line through that so it gets rid of it, because this does not include patient contact. Yeah. Perfect. Yay. More anesthesia. Cleft palate, 8-month-old. Didn't we already do this question today? This one's written differently, but I think we still had the same sort of question earlier. Was it 72 or 76? One of the two. Noon, we're just about to finish. It started 2 hours ago. You want to do it again tomorrow? We can do it again tomorrow. Where am I at? Right here. If I go here and I go to, I don't want to go there. And go here and go to create stream, create a live. Somebody asked for some pocket prep. We could do some of that tomorrow. Reuse. We could do where y'all have to manually code those lovely cases. Tomorrow's the 28th. We can do 4:30 to 6:30. There we go. Just put up the stream for tomorrow, but I'm still working on this anesthesia question. Can we work on integumentary? Yep, we can do anything you guys want. Absolutely. Yeah, like A. A is perfect. Time reporting is extremely important in anesthesia billing. When does anesthesia time end? You need to do practicode. It is crazy, I tell you. Just to do one case is a nightmare. Read that again, Sush. Yep, B is correct. I'm scared of practicode. Ooh. I like to have let's see. And let me grab this chat room and move this to like, I wanna, no, I don't want to make it, no, I don't want that either. I want that, and then I want that. There you go. So, Lord, let's see, I have practicode, so if anybody wants to do practicode and you want me to be your instructor, if you purchase it from me, then I can reset the ones that you get wrong, right? And you can do them again when you finish them. So right now I only have one student, which is Anna. And if we picked a case. Let's see. Somebody said they wanted integumentary. There's a ton of cardiovascular. There's endo, ear, nose, and throat. Gastro, internal medicine, and just plain medicine. There's oncology, pulmonology, psychology, rheumatoidology, urology. I don't guess there's a lot of integumentary here in Practicode. Or I already did those cases. I don't think I did. But, ooh, what a nightmare. Some of them are separated by intermediate. Some are advanced. Some are... I guess that's it. That's all your only options is the intermediate or advanced. Depending on which section you go into. But if I'm your teacher, you know, if you go through all 600 cases, I can go in here and reset the ones that you didn't make a 70 on or above, right? So that you can redo those questions again. And then, of course, I've got a little membership on my website that has all the answers so that you can just check your answers before you hit the submit your case. But it's pretty cool to go in here and try to do it without, you know, looking and see what you can do. You're given like this little claim form that I know you guys can't see much of it, but it's a claim form on one side of the screen, and then on the other side of the screen, you're given the patient chart. And that patient chart is what you code, and then you just fill in the little boxes for the little claim form. But this is one of the cases. Let me make sure and get down so that you guys can see. Let me see if I can make it. Is that too small? It's probably too small. There we go. I'm getting pretty good at this. It just takes me a minute. So, let me get that, and let me get this. And get that. So, sorry, I just miss out on seeing the little girl here that's talking. It's me for just a second. But you're supposed to look at the medical record and decide what header you're under, right, for this visit. Are you in the hospital? Is your patient, you know, where is your patient? So that'll tell you what E&M code category you'll be under for this patient. Let me extend it down. Okay. And you have to figure it out yourself. We can tell that they're established, that this is a regular office visit. So even if it was a consultation, it's still an established consultation. So you still know that you're going to end up being a 9921 something, right? And you just have to pick out your level of visit. What do you guys think this level of visit would be? Oh my God, I'm getting dizzy. Sorry, guys. Yeah, I gave away 3 Pocket Prep memberships today. Hopefully next month I'll have some more in August that I can give away. And I gave away 5 YouTube memberships today for my own YouTube channel. So it's pretty cool. But if you guys were going to code this office visit, what do you guys think it would be? This is case, what number is this one? 7206. Sorry. Patient with lumbar back pain. They didn't really diagnose him with anything. The pain is also associated with headaches. It's no prior history of surgery. Diffuse lower back pain and headaches. They ordered an x-ray. I, like Ian's, said it was a 99212. Cool. Well, now those diagnosis codes. What would you diagnose this patient with? If you went to your ICD-10 book, you'd have to code from here. And your main term would probably be what? Pain? Is that right? I don't know. I absolutely hate diagnosis codes. I don't like doing them. There's pain. Low back. We would get M54.50. And then we have to do headaches, right? And that's usually, I don't know, they may have updated the codes, but isn't that R51.9 for headaches? So that means for this case, what you would have is over here on your claim form, for this case, you just type in your diagnosis codes and your E&M visit and then hit submit, right? And then you'd see what your grade was. But if anybody wanted to do Practicode with me, you guys can do the Practicode with me. And we scored 100% on this one. So perfect. Excellent. Good job, guys. That's it. That's how you do Practicode. We can do some of those tomorrow if you guys want to. I hope today was super helpful, and congratulations to the winners who won the 3 Pocket Prep subscriptions and the 5 YouTube subscriptions. I hope today was super helpful. Anna wants to. Yay! If you got the questions wrong, can you redo them? If I'm your teacher and you purchase Practicode from me, then I have your grades in front of me and I can reset anything that you got wrong. So I don't know how AAPC does it or what, but now that I've purchased the license for it, I'd be happy to do it. I probably wouldn't reset like every single one like the day you got it wrong. Like wait until you got like through all 600 cases and then let me know that you want the ones you failed reset, and then I'll go in there and reset them. That way I'm not logging on all the time resetting 1 or 2 cases at a time. That would be annoying. But yeah, you get a whole bunch of them done and you want me to reset them, I'd be happy with it. Plus, when you do get Practicode from me, you have 18 months to finish all 600 cases. So you could reset even the ones that you got like 80% on until your final report or whatever says that you're like, you know, a super coder, whatever. You know, because they'll give you like this report that you can print out that says your accuracy and all that kind of stuff, that you can attach to your resumes and stuff like that. So it's pretty cool. I don't know where all that's at, but I don't know why it's not showing up. It usually does. It's so annoying that it tells me how well I'm doing on my cases. But usually there's like a fancy little report. They're always changing where they put stuff at. Okay, there we go. So you get your average hours you spent on the cases and how many you've submitted and what your accuracy is and that kind of stuff. So it's pretty cool. They've got some really interesting things that you can submit and add to your resume with these things. Pretty cool. Yes, I can hold your hand. Yes, 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 absolutely. And it is helpful. It's just a lot of cases. It really is. But with me in your corner, I got you. Yep, 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 yep. And we also have this thing on my website right here. This is my website that has this membership, and you just do a search by which case, and you can bring up the scorecard to see what the submitted answer was. In case you're drowning or don't want to wait on me to answer your question, you can search all the case numbers and bring them up if you need to. So, but hopefully you won't need any of that. But it's there on my website. I've got all 600 cases there if you need it. Plus, I'm going through them again right now just to make sure what I've got on my website is the same as what's there now. But I've already done them 3 times now, all 600 cases, just because I like making sure that nothing's changed. Sometimes they do update their answers. Like they used to charge for some of their procedures, the monitored anesthesia, the 99152 codes, and now they took all those off because it's included in the CPT code descriptor. I don't know why they used to recommend that they had to have them there anyway, because we weren't billing for the anesthesiologist, we were billing for the physician to do the procedure. Anyway, so sometimes they change things and take things off, but it's pretty cool. This Friday, yes, is 11:30 my time, and probably out there on the East Coast would be 3:30 your guys' time. I hope to see you guys in our little Zoom class on Friday too, which is super helpful. All right, guys. The replay for this live will be up on YouTube if anybody wants to watch it and go back over some of the questions that we did. But I'll see you guys same time tomorrow. Yes, you can take Practicode if you have not taken your exam yet. Yes, that's not a requirement. You can take it. You can do all 600 cases and push off your exam attempt if you want to. That's totally up to you. And you have 18 months. So even if you take your CPC exam in like 30 days and you maybe only do 10 cases between now and then, it's fine. There's no mandatory, you must be certified to get into here kind of like thing. You're welcome. You're welcome. All right, love you guys. See you guys tomorrow.